Hello friends, welcome once again. Today we are going to talk about approach to chronic vomiting in pediatrics. Now, vomiting in children encompasses a whole gamut of causes. Reaching a clinical diagnosis guides further investigations for confirmation. Now, instead of searching for the needle in a bundle of haystack, a methodical approach usually aids in making the right diagnosis and channeling the appropriate treatment. So let's dive in and get started. Now, by definition, chronic vomiting is defined as persistence of vomiting for more than 4 weeks. So, a child of any age, if he is vomiting, which might be continuous or might be on and off, but the history is of for more than 4 weeks, then we call it as chronic vomiting. Now, Rome 4 criteria, which is actually a criteria which classifies many gastrointestinal pathologies, that defines chronic vomiting as chronic nausea and vomiting for more than 2 months. So Rome 4 criteria actually puts it uh, for more than 2 months. But basically, for practical reasons, we take chronic vomiting as vomiting which is more of 4 weeks duration. Now, chronic vomiting per se is not a very common presentation, but when it does present, like when children come to the emergency departments or clinics with this problem of chronic vomiting, then that actually presents as a great diagnostic challenge because the spectrum of etiologies is very wide. You can have gastrointestinal pathologies and non-gastrointestinal pathologies, and there could be a myriad of different causes and pathologies which might be responsible for chronic vomiting. So it presents a diagnostic challenge. Uh, Therefore, a sound clinical approach is very important because it would address any emergent issues. Like, for example, if there are any emergency features associated with chronic vomiting, you can address that as well. And at the same time, you can do your workup to find out for the reasons which might be causing that chronic vomiting. Now, spectrum of causes is very wide, but certain pathologies they present at a specific age group. Like certain causes would be more common in the neonatal age group, certain common etiology would be more common in the older children, and certain then etiologies are more common in the adolescent age group. So we can break down the etiologies according to the age groups, which can further help in, you know, channeling the diagnosis. So moving on to the different types of reasons or causes that can cause chronic vomiting. Uh, I will show you this chart now. This chart actually is in basically a very good dissection of chronic vomiting because it is actually giving you an overview of the different groups of causes that can present with chronic vomiting. So by and large, if you see the chronic vomiting is divided into two groups. So one is the what we call as gastrointestinal causes. So here the pathology lies somewhere in the gastrointestinal tract. The other group is what we call as extraintestinal causes. So here the causes are lying outside the GIT. So it might be in the endocrine system, it might be in the neurological system, it might be in the genitourinary system, wherever it is, but it's not there in the gastrointestinal tract. Now, because gastrointestinal tract causes are more common, again they can be divided into obstructive and non-obstructive causes. Now, obstructive causes are those causes in which there is some form of anatomical obstruction anywhere along the gastrointestinal tract. It might be at the level of esophagus, it might be there at the level of stomach, might be down in the small intestine or large intestine. Wherever it is basically an obstructive lesion. So an obstruction to the flow of the food that a child takes, that would actually cause stagnation of food, like before that point where the obstruction is, and that can lead to vomiting. And if it is a chronic cause, something which is there for a considerable period of time, then obviously the vomiting associated with that would also be chronic vomiting. So as far as the obstructive causes are concerned, it could be anywhere starting from the esophagus down to the large intestine. Now let's talk about some of the causes. Like in esophagus, if there is an obstruction, usually this obstruction could be in the form of achalasia. This could be in the form of a structure in the esophagus. But if the problem is in the esophagus, then the type of vomiting that the child would present would be basically uncurdled milk in the vomit. If it's a small child, the milk that he throws up would be liquid, it would be uncurdled. And curdled milk basically means that it has been acted upon by the acids, and at least it is at the level of stomach. So if it is uncurdled milk and the child is vomiting very quickly after feed, that basically shows that the obstructive lesion in the GIT is quite proximal, especially esophagus. And that's, you can then think of the causes in esophagus that can cause chronic vomiting. If the lesion is at the level of stomach, then stomach has got acid, and acid then acts on the milk to curdle it. So if there are, the vomiting consists of curdled milk or stale food like the undigested food that the child has taken, and usually this is in large amounts because stomach can hold up a large amount inside. So that basically means that the obstructive lesion could be somewhere in the stomach, like pyloric stenosis. Similarly, if a child is having bilious vomiting, any color of green, now that is what we call surgical emergency, because it simply means that the obstruction is beyond the ampoule of water. And usually these types of obstructive lesions would present with abdominal distension as well. The child may be very sick, especially if there is complete luminal obstruction. But sometimes, in certain cases, if there is an incomplete malrotation of the intestine or something, then it can present as a subacute condition, and usually they would be having chronic vomiting. So, any type of obstructive lesion distal to the ampoule of water, that is a second part of duodenum, would lead to bilious vomiting. And the common cause usually here which we see is malrotation of the small intestine. Similarly, if the obstruction is at the level of colon, then usually the vomitus is more of a feculent vomiting, as it contains fecal matter and has got a very nasty bad smell. It would be usually associated with constipation, and there would be quite massive generalized abdominal distension. So again, in a nutshell, the lesions, obstructive lesions, can be in any part of the gastrointestinal tract. And again, the type of vomitus can give you an idea where is that obstructive lesion. So there can be obstructive lesion anywhere along the whole path of the gastrointestinal tract, and remember, it would be the type of vomitus and some associated features which would give you a clue where the obstructive lesion is. Now, then coming to gastrointestinal causes which are non-obstructive in nature. So here the child has got chronic vomiting, but there is no anatomical obstruction. Usually the common pathologies here are gastroesophageal reflux disease and cow milk protein allergy. Now these are quite common in the young age group, in the toddlers, in the infants. And basically what happens in gastroesophageal reflux disease is that the lower esophageal sphincter is very incompetent. So there is reflux of the stomach contents back into the esophagus, and they eventually come up. So it could be in the form of regurgitation, but frankly, it can be in the form of vomiting as well. And this vomiting would be over a period of time, leading to that condition which we call as chronic vomiting. Or it could be cow milk protein allergy, again, which is a myriad of different signs and symptoms. The child is fussy, usually cries a lot, has got refuses feed, sometimes can have rashes, and has got diarrhea, which sometimes might be blood tinge as well, and they usually vomit after the milk feed. So cow milk protein allergy and gastroesophageal reflux disease are two very important non-obstructive reasons of chronic vomiting. Similarly, some kids have got the issue of rumination, or in which there is like habitual uh, regurgitation of the stomach contents back into the mouth. And these are the kids who have got some form of psychological issues. We also call it psychological vomiting. So that is also a form of gastrointestinal non-obstructive chronic vomiting. Now, coming down to some of the important causes, which you call as extraintestinal causes, where the cause is not in the intestine but somewhere else. If a child has got altered sensorium, along with chronic vomiting, if he has got altered sensorium, it means that the child is not well oriented in time, place, or he's got like drowsy, or he's comatose, And if that is triggered by infections, like he was fine, but all of a sudden he had gastroenteritis or an upper respiratory tract infection, and after that he started having chronic vomiting and has got acidotic breathing, then usually these types of chronic vomiting is caused by different types of inborn errors of metabolism, like urea cycle defects, like organic acidemias. Basically, these are enzymatic issues. So when the child is under stress and there are enzymatic deficiencies, so what happens is that the pathways are blocked, leading to overproduction of certain chemicals, which actually then trigger the vomiting center, and it leads to vomiting. So inborn error of metabolism, which are lot, there's a list is a huge one, beyond the scope of this lecture, but usually urea cycle defects and organic acidemias, galactosemia, hereditary fructosemia, things like that, they can cause chronic vomiting. Similarly, if a child has got headaches, visual disturbances, focal neurological deficit along with chronic vomiting, that basically signifies a pathology somewhere in the nervous system. Especially, you should be very much thinking of CNS lesions, like especially the pressure producing CNS lesions, like brain tumors. They can cause chronic vomiting, and it's usually with early morning headaches and focal neurological deficits. Similarly, if it is associated with fever, burning, micturition, then you should be thinking of renal disorder. Sometimes, if there is also associated with anemia and growth failure, then other types of renal disorder, like renal tubular disorders, can also be the cause. So, renal disorders basically can be divided into infectious and non-infectious. So, infectious ones are actually your urinary tract infections, which can cause vomiting, and if it's a chronic urinary tract infection, then obviously it will lead to chronic vomiting. But some of the other non-infective pathologies in the kidneys, like renal tubular acidosis. So, renal tubular acidosis, if it is a proximal or distal one, that can cause vomiting, that can cause growth failure, and that can cause anemia as well. So, different types of renal tubular acidosis can give rise to chronic vomiting, but in that particular condition, you would see that there will be an element of growth failure and anemia as well. If the chronic vomiting is associated with electrolyte disturbances like hyponatremia, low sodium, high potassium, or high calcium and high blood glucose, then you should be thinking of endocrine disorders like Addison disease, like congenital adrenal hyperplasia. So they can cause vomiting, and that vomit is usually chronic vomiting. And sometimes we don't find any reason, like all the extensive investigation and blood tests and workup is usually negative, and these are the kids where there is a pattern to it, like they would vomit with abdominal pain, headaches, then they are fine, then the cycle comes again and goes, so they are exacerbation and remission. We call it as cyclical vomiting syndrome, which is basically a diagnosis of exclusion and is usually associated with some form of migraines. So, by and large, again, if we have to summarize this, the causes of chronic vomiting can be divided into gastrointestinal and non or extraintestinal. Again, gastrointestinal can be divided into obstructive one, which can be anywhere from the level of esophagus down to the colon, and the non obstructive one, especially gastroesophageal reflux disease and cow milk protein allergy, which are very important problems of the infants, even neonates. Similarly, extraintestinal causes, remember the important are endocrine causes like Addison disease, like congenital hyperplasia. You can have chronic vomiting in neurological disorders like brain tumors. You can have it in renal problems, infective renal problems, as well as non-infective renal problems like renal tubular acidosis, and you can have it in metabolic problems like uh, wide variety of inborn errors of metabolism like galactosemia, urea cycle defects, fructosemia, and so on and so forth. Okay, now moving on to the diagnostic pathways. Remember, the most important thing is a detailed history. So, the very first step, like for example, if you are looking after a child who's got chronic vomiting, so the very first step is to take a detailed history. So, for how long the child has been vomiting, what has been the consistency of vomiting, frequency of vomiting, associated features, all those things. So, you have to take a very detailed history, and uh, that should be followed by a detailed examination. And this detailed examination, obviously, you'll be doing head to toe examination, but it should be specially focusing on your general examination. So, you look at whether the child is stunted, whether he's wasted, whether he's anemic, whether he has got short stature. Then you would do a detailed gastrointestinal tract examination. You look for any masses, you look for any signs of GIT masses. You will do a complete neurological assessment looking for any focal neurological deficit. And last but not the least, you need to do a proper genitourinary examination as well. As I told you, that many renal disorders can present with chronic vomiting. So once you have done your basic examination accompanied by a good history, then you have to do certain basic workup that includes your full blood count, urine electrolytes, LFTs, lactates. Blood gas is very important work because it gives you whether the child might be having acidosis or alkalosis, which can help in pinpointing the certain types of chronic vomiting. And urinalysis is also important because urinalysis can give you an idea if the child has got UTI or he might be suffering from renal tubular acidosis. So once you have taken a detailed history, you have done your examination, and you have done some basic workup, like including blood workup and urine analysis, then at that point in time, you would be able to classify it broadly. Either it is a gastrointestinal problem or either it is an extraintestinal problem. So with the history, good examination, and basic workup, at least you can dichotomize the chronic vomiting causes either into gastrointestinal or extraintestinal. So once you know whether it's gastrointestinal or extraintestinal, then you can further channelize your appropriate workup. So as far as the further workup is then concerned, uh, you need to do abdominal exit. Like if you are suspecting gastrointestinal causes, so you can look at the abdominal x-ray. So if the abdominal x-ray is showing like a lot of gases, air fluid levels, things like that, then you can think of an intestinal obstruction. Similarly, in certain cases, ultrasound can help. Like ultrasound can help you in diagnosing pyloric stenosis, especially if the antral thickness is more than 3 millimeter and the length is greater than 12 millimeter. Similarly, it can also help you in picking up certain conditions like intussusception. Um, if ultrasound doesn't help you, then you can do what we call as upper GI series, which includes endoscopy as well, which also includes giving a barium meal and then doing serial X-rays, and that can actually highlight some of the gastrointestinal pathologies. Like for example, if there are certain types of constrictions, achalasia, duodenal narrowing, things like that, so they would be pick up on the upper GI series. And if even those they are inconclusive, then we have got advanced diagnostic modalities like oral contrast enhanced CT scan or MRI, which can pick up conditions like superior mesenteric artery syndrome. It can present up some of the other causes which are usually not picked up on the X-rays, ultrasound, and upper GI series. If you are suspecting extraintestinal causes, then obviously you might have to do different type of studies, and again your findings would guide that. You might do enzymatic studies, especially if you are suspecting inborn errors of metabolism. So that can start with very simple ones like checking urine for reducing substances and checking uh, blood ammonia levels, and from there you can take it up like in either direction, whatever you are suspecting. Similarly, you can do hormonal studies if you are suspecting hormonal problems like Addison disease, like chronic congenital adrenal hyperplasia. You can do cortisol, and then the other types of studies in which you actually do the hormonal assays. Similarly, if you're suspecting neurological problem, then you can do a CT or the MRI. MRI is actually preferable in kids because of the less radiation, and its yield is far better because if you're suspecting tumors, most of the tumors are infratentorial, and CT scan is not good in picking up infratentorial masses. So in that particular case, MRI is a better diagnostic modality that can help you in picking up those lesions. Then coming down to the treatment. As far as treatment or management is concerned, number one, it would depend on the underlying issue. So, if there is any underlying issue, the particular treatment of that issue should resolve chronic vomiting. But usually, if the kid is coming to the emergency department, so obviously, if there is any acute issue associated, even if it is a chronic vomiting, but they have got an acute issue, like for example, if they are dehydrated or they are hypoglycemic, then you have to address those acute issue. So you would like give them something to replenish their glucose levels, or you might give them IV fluids. If they've got any deficit or if they've got ongoing losses, you might have to give them maintenance fluids. Anyhow, so you will manage any acute associated issues with that. Usually that's dehydration, and if there are any electrolyte imbalances, you will just address there and then. Then again, as I told you, you have to take a detailed history, you have to you have to do a detailed examination and do a basic workup, and that would actually guide you whether it's a gastrointestinal pathology or extraintestinal pathology. So if you are suspecting obstructive gastrointestinal pathology, so that becomes basically a sort of an emergency. So usually the first line treatment is that you have to put them what we call as a nil by mouth. So you have to stop all oral feed, you have to do the decompression. So you put a NG tube and you do the decompression. So you take the pressure off the intestine so that they do not rupture. You would give them maintenance IV fluids, you might have to give them antibiotics, and as soon as possible surgical consult, because most of these cases would be surgical cases, so they would require some form of surgical treatment. So the earlier you do, the better are the outcomes. If you are suspecting cow milk protein allergy, which is one of the common non-obstructive gastrointestinal cause in infants, then elimination of milk products of at least for 6 months. And those who have got IgE mediated mean those who have got like severe rashes, asthmatic, and can develop anaphylactic like reactions. Usually they've got very high levels of IgE in there. So those types of reactions, for that at least 6 months of milk exclusion or milk product exclusion. And in those who are non-IgE mediated cases, they're somewhere around 12 to 18 months of milk product exclusion. So you have to exclude milk and products made up of milk and put them on hydrolyzed formulas like Nutramigen with LGG, or alimental formulas like Neocate, so on and so forth. If it is gastroesophageal reflux disease, so usually a nice guidelines, so you should start with feed thickening. So you give them some form of feed thickness, which could be in the form of like regurgitation formulas, or you can give them like infant Gaviscon in their feeds, which actually helps in thickening the milk and prevent regurgitation. So if that is not working, it should be followed by proton pump inhibitors. Similarly, in these kids, because sometimes it's very difficult to differentiate gastroesophageal reflux disease from eosinophilic esophagitis. So if the proton pump inhibitors, they are failing, the child is not improving on that, or if they are stabilized, but then weaning off like from proton pump inhibitors difficult, as soon as you try to wean them off to lower doses, the symptoms return. Then in that particular case, you should be considering eosinophilic esophagitis. Now, basically, this is a entity which can only be diagnosed by biopsy, doing an endoscopy and biopsy. But clinically, a child who presents with gastroesophageal reflux like symptoms and is not improving on proton pump inhibitors, even on high doses, then you should be thinking clinically it might be eosinophilic esophagitis, and further workup like endoscopy and biopsy might have to be done. But on a non-invasive side, you can offer them 6 food elimination diet, like Nelson textbook of pediatrics 21st edition. It says that if you are not doing that, then give them this 6 food elimination diet. So you have to eliminate cow milk from their diet, you have to eliminate soy protein from their diet, you have to eliminate eggs from their diet, you have to eliminate fish from their diet, you have to eliminate wheat products from their diet, and you have to eliminate nuts from their diet. So these 6 things have to be eliminated from the diet. Then you will say, okay, well, if you eliminated all these major things, what is left for the child? Rice based products, fruits, vegetables, or their mixes. So that has to be done at least for 6 weeks, and it says this is uh, at least 74% efficacious. So of 100 kids who are suffering from this, and you put them on the uh, diet, 6 food elimination diet for 6 weeks, 74 of those 100 would improve. Similarly, those who are not responding to proton pump inhibitors, for that we can try oral viscous budesonide or oral fluticasone. Now again, this have been mentioned in the Nelson textbook of pediatrics. So oral fluticasone, fluticasone basically is a spray which is used in asthma. So that can be given to the child, 2 puffs in the morning and 2 puffs in the evening. But oral simply means that you're not giving it through the spacer. You just put it in their mouth and you give them 2 sprays. So then as the child swallows his saliva, then it will go down. So oral fluticasone for a few months can be tried. Uh, Again, 70 to 74% improvement. Or more recently, oral viscous budesonide has also been tried. Now, budesonide, basically is used as an inhaler as well as a nebulizer. We use it as a nebulizer in croup. It is also used as an inhaler in asthma as well, as a preventer therapy. So the Pulmicort, the nebulizer solution, which usually comes, I think, is from zero point 0.5 milligram. So zero point 0.5 milligram is then mixed in 5 ampules of concentrated sugar, like sucrose solution, and a solution is made. So 1 milligram is given per day of budesonide. So that basically the nebulizer solution mixed in sugar solution, thickened sugar solution, and given to the child. So he drinks that, and it goes and touches the whole of the esophagus. They say that that actually works like magic for those children who are suffering from eosinophilic esophagitis. And where you would be expecting eosinophilic esophagitis, usually kids who are presenting with GERD like symptoms but not responding to proton pump inhibitors. Similarly, Nelson textbook of pediatrics also mentions about some new novel drugs, which are the interleukin 5 inhibitors. Uh, Mentioning the names mepolizumab and racizumab are the two medications which have got very good um, effects in treatment of eosinophilic esophagitis, but they are currently under trial and they're quite expensive drugs. Okay, as far as superior mesenteric artery syndrome is concerned, now superior mesenteric artery syndrome is a very treacherous thing. Usually, this happens in adolescents, and those adolescents who have got some history of anorexia nervosa. So, usually, these are the kids who are trying to lose their weight very rapidly. So, what happens is basically from the aorta, the superior mesenteric artery, as it comes out, it makes an angle, and this angle, and basically between the superior mesenteric artery and the aorta lies the second part of the duodenum. So usually there's a fat pad between the superior mesenteric artery and the duodenum. But those kids, adolescents especially, who are like and having anorexia nervosa, are quickly reducing their weight. That's fat pad is gone. So the esophagus is actually sort of niched between the aorta and the superior mesenteric artery. So it causes a sort of an extrinsic compression and blocking of the uh, duodenum, which causes intractable vomiting and further weight loss. So, if you are suspecting a superior mesenteric artery or artery syndrome, usually it is diagnosed by doing an MRI with contrast. So that is one of the diagnostic modalities of choice for diagnosing superior mesenteric artery syndrome. That is MRI with oral contrast. So if that is a condition, there are two choices: either medical or the surgical. Medical side, hyperalimentation, in which you have to give them intravenous alimentation, or going nutrient through the central venous lines, or you can do what we call as a nasojejunal feeding. So a tube is passed and that goes beyond that level of obstruction into the jejunum, and the feeds are given through that, if the child can tolerate that. If not, then some form of duodenojejunostomy has to be done, and that is basically the domain of pediatric surgeons. So pediatric gastrointestinal surgeons, like surgery has to be done if everything else fails. And then coming down to the cyclical vomiting syndrome, in which the child has got cycles of vomiting every few weeks to few months, usually associated with abdominal migraine. So usually, if a child comes with an acute attack, so you have to control that acute attack. And usually, we give them painkillers. We usually give them dextrose-containing IV fluids, along with ondansetron, which is a 5-hydroxytryptamine 3 receptor blocker to stop the vomiting, and some form of sedation, so that they are not that much retching and in discomfort. But long-term medications can be given to them, like cyproheptadine and pizotifen if they are less than 5 years of age, or amitriptyline if they are greater than 5 years of age, to control this long-term aspects of cyclical vomiting syndrome. If these things are not working, then second-line medications can also be given, like propranolol and some enzymes like carnitine and coenzyme Q, which are which have got some efficacy. It's not that great, but at least it can be tried if the first line medications are not working. So in a nutshell, the management depends on the underlying cause. So you need to have a working diagnosis in order to offer them treatment, because the treatment differs according to the cause. So remember, in chronic vomiting, the summary is that you have to find the exact pathology that is causing chronic vomiting. So you have to first of all decide whether it is gastrointestinal or extraintestinal. If it is gastrointestinal, whether it's obstructive or non-obstructive. And if it is extraintestinal, then you have got different types of diagnostic modalities which can actually pinpoint whether this thing is coming from some lesion in the neurological system, or it is coming from the endocrine system, or it is coming from the genitourinary system, as I already explained in my lecture. So this was a short lecture about chronic vomiting in pediatric population. I know you would be definitely having questions regarding this, because this is a treacherous topic, and the more we try to address the issues associated with chronic vomiting, more questions are also more questions are also arise because of the complexity of this topic. So still, if you've got any question, you can put it down in the comment section below, and I will try my level best to answer them as soon as possible. So if you have liked this video, give us a thumbs up, and if you haven't subscribed, what are you waiting for? Do subscribe and share it with your friends. Have a very good day. Bye bye.